Hello, everyone. My name is Dr. Yonit Arthur. I'm an audiologist and coach. You are on the Steady Coach. Today, I am recording for you a presentation that I'm going to be giving at a professional conference for medical professionals. And the reason I'm recording this for you is because I think this information should be available to everyone. I also think that it's important that you have something like this to share with medical professionals, healthcare providers, and other people in your life who need to understand kind of the technical background of why neural circuit dizziness can be addressed using all the things that we talk about on this channel. So, you are welcome to share this far and wide if you find it useful. I do just want to say that because this is a presentation for medical professionals, I'm going to be using a lot of technical language and jargon today. And if you find any of what I'm saying confusing, please don't worry. You are not missing out on any information that you can't find elsewhere on my channel explained in much more detail. All right, so let's get started. Not just an ear. Biopsychosocial assessment and treatment of chronic vestibular disorders.
And then as soon as I started taking a few steps, my life completely changed. I felt like true vertigo symptoms of like spinning around. The world was feeling like it was an ocean. I was about to go to bed and I remember like getting into bed and it felt like the bed was moving up like 8 to 10 feet in the air. When I was standing still, I was feeling this like really strong up and down pull. Feeling like the ground is uneven, the ground is moving, that it feels like the floor is almost like
Yeah.
Minecraft or something where the blocks are like lower or higher. The symptoms were pretty much constant and at a high level. I was terrified, just so at a loss for words. And I really just in a total fight or flight. What the hell is happening?
And I literally felt my brain was being fried on a pan. It was that much heated. Then I had auditory hallucinations, and there was this feeling of intense doom. Anything bad is going to happen to me. I didn't know how to describe it to anyone. Then I felt electricity flowing in my nerves with each breath. I had lightheadedness initially, followed by heavy headedness and sand feeling in the head. Like if I would move my head, I would feel something, the sand or something in my head which is moving. I couldn't walk. I couldn't sit. That was unbearable. All I did in the first initial couple of months was lying down and I had this extreme rocking sensation. Then I had those dizzy spells, there's the elevated drop. Then my heart rate was increased, going up to 130, 140 baseline. And I felt the extreme fatigue. This is what I remember. I'm pretty sure there were many more symptoms.
When I woke up, everything around me was different. I suddenly couldn't focus on things. I couldn't track things. So I was looking back out at that lake and I was thinking, I can't see what I saw literally like an hour ago almost. I started to just feel like I wasn't with it. I couldn't concentrate. And underneath it all was this sense of just, it was like impending doom, impending dread. My whole vision at one point was just black dots and it literally would be like snow falling. There was no relief from it. It never came and went. I would look around and people would walk past me and I could only see half of their face. And suddenly the corridors bouncing, shaking, vibrating. And then it tilts, everything starts tilting. And I'm suddenly woozy and holding onto the side. Insomnia kicked in. I just couldn't sleep anymore. Extreme sensitivity to any kind of physical movement. So I'd be trying to lie in bed next to my husband, and all he'd have to do was move his toe. And I would be like an electric jolt, your head spinning, trying to sleep, feeling like my body was rocking up and down, swaying side to side, something inside constantly bouncing and tremoring all the time. But no one can tell me what's going on.
In most clinical settings, these three patients would be diagnosed with a chronic vestibular disorder. Alex would have been diagnosed with Malda de Barkmont syndrome, or MdDS. Dr. Uzma would have been diagnosed with vestibular neuritis and vestibular migraine. And Rhea would have been diagnosed with PPPD, or persistent postural perceptual disorder. The three of them would likely be told some variation of the following. You have a chronic condition that can only be managed and will be lifelong. Your best chance to have a better quality of life is to take medications, but those medications will not stop the symptoms completely or at all. Vestibular therapy may be helpful in reducing symptoms. And if they're really lucky, they might be told to reduce stress, change their diet. That may help. Good luck with your new diagnosis of a chronic vestibular disorder. In fact, here are some real life examples of what real people have been told by their medical providers. I was told that there was no treatment for it. I was told my option was to try medication to see if it could lessen the symptoms. What I interpreted that to mean was that basically I'm stuck feeling this way forever. I had an appointment with an ENT specialist, and his nurse came in and said that he didn't find a need to see me. I explained to her what was going on, and she said, maybe you want to think about contacting a psychiatric hospital. I was told that I should just go home, and if I'm lucky, I'll have more good days than bad days for the rest of my life. No cure. The best case scenario, I would go into remission, but would suffer from flare ups. And if I stayed flared up for too long, the chances of getting out of remission would be slim to none. My symptoms got much worse after my diagnosis of vestibular migraine and PPPD, which I don't use anymore. I believe being diagnosed and told this was a chronic illness with no cure was the worst thing anyone could have said. In these stories, you can already see this theme developing that the biomedical model in which most of us practice has limitations for these patients. The biomedical model is the dominant paradigm in Western medicine and in audiology. It views symptoms as arising from structural, cellular, chemical, or other biological abnormalities and focuses treatment on fixing or managing those physical causes. The biomedical model, of course, excels at diagnosing and treating structural pathology. But when applied to dynamic plastic conditions, which many vestibular disorders are, as we will soon discuss, they become a blunt force instrument, and this falls short of what a patient needs. We know the stats on vestibular disorders, and I'm sure you're living and breathing this in your practice if you see people with vestibular disorders. They have devastating effects on quality of life, activities of daily living. They cause physical impairment, lost wages, inability to work. Approximately 50% of people with chronic vestibular disorders have clinical anxiety and depression. Approximately 50% report cognitive difficulties, memory issues, and brain fog. And this isn't discussed as frequently, but I think this is equally devastating. These people undergo a disintegration of identity and the creation of a new identity as a lifelong patient who sees him or herself through the lens of the disorder as a chronically sick person. My question for you today, and one that I hope I can answer for you, is what if there's a better way? What if it's not actually true that management is the highest bar we can set, at least for some of these patients, and definitely not for the three I showed you earlier? What if, as medical professionals, we can change the trajectory of these patients' lives? What if we can empower them not just to take control of their health, but also to reduce or even eliminate symptoms in some cases, and in all cases, see their symptoms as an experience they're having, not as an identity to form their lives around? In service of this, we're going to be talking about the biopsychosocial approach to chronic vestibular disorders today. The biopsychosocial model is a multifaceted approach to understanding and treating diseases that considers the biological, psychological, and social factors contributing to their development and persistence. Biological meaning structural problems, disease processes, tissue damage, traumatic injuries. Psycho relates to the patient's background, history of trauma, coping, resilient skills, personality. And social relates to the person's social context, environment, beliefs about illness and about self, social support system, family dynamics, and more. So today we're going to be first talking about some background information on dizziness and chronic dizziness. I'm then going to introduce you to a spectrum model of vestibular disorders. We're going to be taking a closer look at vestibular disorders through a biopsychosocial lens. We're going to then discuss the limitations of current biomedical approaches and vestibular therapy. And we're going to talk about psychosocial interventions and why those need to be part of treatment too. By the end, I hope that I can help you reconceptualize assessment and treatment of chronic vestibular disorders. So, before we get into it, a little bit about me. I'm an audiologist licensed in Florida. I'm board certified. I graduated from Purdue. I worked in a variety of settings until I burned out and quit in about 2018. And I rediscovered my love for audiology through a series of circumstances, and since then have worked exclusively with people with chronic vestibular and dizziness disorders in my private coaching practice. I run that plus provide free education via weekly YouTube videos and an online free course that has to date been taken by over 20,000 people. I'm certified in vestibular rehabilitation, concussion management, and advanced vestibular rehabilitation through the American Institute of Balance. And relevant to this discussion, I have been trained extensively in a wide range of counseling modalities, including internal family systems, accelerated experiential dynamic psychotherapy, and other methods specifically for the treatment of neural circuit or neuroplastic disorders, and inference based cognitive behavioral therapy and exposure and response prevention for anxiety and OCD. I've also been trained extensively in mindfulness. I work with people with chronic dizziness full time, and it is my passion to help as many people as possible, not just by providing them with education and tools, but also by educating you, the medical professionals who I know so badly want to help them too. So, any of you who work with vestibular patients regularly are probably quite familiar with how the vestibular system works. There are four total components: the eyes, ears, and sense of touch or proprioception. And of course, the brain, the central processing, integrates all of this data. Now, the first thing we need to discuss is how sensory perception actually works. Some of the newer graduates here may know this, but this was actually surprising for me to learn because bottom up processing was so heavily emphasized in my education. How sensory perception works is that the brain maintains internal models, which I'm going to refer to as predictions or predictive maps, and it compares sensory data to these predictions. This is far more efficient than bottom up processing. When significant errors occur, that is, when sensory data does not match predictive maps, this typically drives internal model updates. And this includes changing the weighting of various streams of sensory data, especially in multisensory systems like the vestibular system. For example, visual dominance, a phenomenon very common in people with vestibular issues, since vestibular input is deemed unreliable by the brain. The brain then updates the weighting to increase relative importance of visual data. And then when someone goes to vestibular rehab, that reverses that process. This illustrates this is not a static thing. These predictive maps are not static. This update process is an ongoing dynamic process. The brain is always updating its predictions. And this is how this might look. So, when the brain predictions are correct, meaning the map matches what the sensory data says, we are steady. When the map does not match the sensory data, we are not steady, we are dizzy. The brain then recognizes this prediction error, and the internal model updates to reconcile these differences. Chronic dizziness occurs when this internal model update process does not go as planned. And it doesn't go as planned for two reasons primarily. As medical professionals, we are very comfortable with reason number one, chronic sensory issues or disease processes. But we tend to think about reason number two a lot less, and that is failure of the central nervous system to adapt. And we will talk about at length why this happens later in this presentation. But because we tend to be biased toward medical causes or biomedical causes, reason number one, first of all, we're likely to tell a patient that the condition can only be managed if they have not improved on the treatment that we've given them. We are likely to say things like treatment has failed because we haven't tried the right medication yet and keep trying new medications. We might suggest more exercises or more dietary changes. But there's a different explanation for why treatments aren't working if we're willing to look at reason number two. The reason treatments often fail is we are addressing reason number one when reason two is why the person is dizzy. And I'm going to make a good case today for why we need to think about reason number two more often than reason number one. So, what are chronic vestibular disorders? Chronic vestibular disorders occur when the brain doesn't or cannot adapt to sensory reality for either reason number one or reason number two. So, let's get into the specifics. When something goes wrong in one or more of the four components of the balance system, interfering with the brain's perception of orientation, motion, and position, we call this a vestibular disorder. And this is often accompanied by dysfunction in the perception of more than one of the senses involved. For example, vision disturbances. We typically think of this in two categories: central vestibular disorders, being driven by an anomaly in vestibular processing, or peripheral vestibular disorders, being driven by an anomaly in peripheral organs related to balance. But there are two problems with this categorization. First of all, some people with peripheral anomalies aren't dizzy. So a peripheral anomaly does not explain chronic dizziness in all cases. And some people have a peripheral anomaly that then goes away and yet they stay dizzy. The second problem with this classification is that central includes biological disease processes like brain tumors and strokes that require medical intervention, as well as vestibular processing disorders that do not respond to medical intervention. Both may involve changes in the brain, but one reflects a permanent process only treatable with medication or surgery, and the other reflects a neuroplastic process, a process of brain reorganization. We're going to learn a lot more about this today. But this is why I prefer to think of dizziness disorders as being on a spectrum. This spectrum shows that this is not a hard categorization. Vestibular disorders are on a spectrum relating to how much a condition is influenced by fixed structural problems or plastic processing problems. And this spectrum is my own creation. So, a structural condition is driven by identifiable changes in physical structure or tissue, either centrally or peripherally, for example, vestibular schwannoma. These are often acute issues, though not always, and typically align well with a biomedical model. There is a clear lesion, dysfunction, or mechanical issue that can be directly observed and treated. Now, over on the purple end of the spectrum, we have neural circuit conditions, and these arise from changes in how the brain is processing information. These conditions are functionally real. They are associated with measurable changes in brain function, biochemical changes, and even structural changes, and produce the same issues in predictive processing as structural conditions, which means they cause the same dizziness symptoms, but they do not reflect permanent or progressive tissue damage. The cause is different, not the symptoms. These symptoms emerge from patterns of activity and connectivity that have been altered through neuroplasticity. In other words, the brain has changed, but it hasn't broken. And because the brain is plastic, these conditions are potentially partly or completely reversible under the right circumstances when we use the right tools. That distinction between structural damage and modifiable neural circuitry is the key to understanding why traditional biomedical interventions fall short for conditions on the purple end of the spectrum. Don't worry, we're going to talk more about these specific conditions shortly. But first, I want to just orient you to just how many of your patients likely have these conditions first. PPPD, or persistent postural perceptual disorder, and vestibular migraine account for the majority of chronic vestibular symptoms. Now, this chart does exclude BPPV because that is usually acute or recurrent. And if it does result in constant or chronic symptoms, that typically qualifies the patient for a PPPD diagnosis. There are also some representative slices here from Meniere's and MdDS, or Malte-Debarkmont syndrome, as well as third window syndrome and other central causes. This is just to illustrate just how many of your patients with chronic vestibular symptoms have what is a neural circuit condition, which likely requires different assessment and treatment protocols for optimal outcomes. So let's go back to our spectrum, and I'm going to introduce you now more deeply to some of the chronic vestibular disorders that we're talking about today, and of course, the most common ones in particular. PPPD, again, is persistent postural perceptual disorder. Persistent non spinning dizziness or unsteadiness, persisting 3 months or more, present most days, and exacerbated by upright posture, active or passive motion, and exposure to complex visual stimuli. Onset is often precipitated by an acute vestibular event, medical illness, or psychological stressor. Structural and peripheral causes must be ruled out. Essentially, what this means is you're dizzy most of the time, and we don't really know why you have persistent symptoms. PPPD arises from altered processing in the brain's threat, balance, and visual motion systems. There is no structural damage that explains the chronic symptoms. Instead, there is heightened vigilance, increased reliance on visual input, and dysfunctional sensory integration. It is entirely neuroplastic and reversible, which places it firmly at the neural circuit end of the spectrum. MdDS, or Malte-Debarkmont syndrome, is a persistent perception of rocking, bobbing, or swaying, usually following exposure to passive motion, such as a cruise, flight, or long car ride. Symptoms are typically relieved when in motion and worsen when still. They must persist for at least 3 days and cannot be explained by another condition. In other words, you feel like you're moving all the time and we don't know why, but we know your brain has not adapted back to being still. MdDS reflects a failure of the central nervous system to readapt after motion exposure, rooted in persistent activation of motion perception circuits. There is no evidence of structural damage, and the condition can be modulated by neuroplastic interventions such as visual vestibular adaptation therapies, solidifying its place as a neural circuit condition. And before we go on, I want to say that the reason I'm talking about MdDS is because, in my experience, there is a tremendous overlap between patients who are diagnosed with PPPD and patients who are diagnosed with MdDS. So, although MdDS reflects a relatively small proportion of the diagnoses that we saw in our pie chart, I think it's very important to include here, as many of the patients you see may be concurrently diagnosed with both and meet the diagnostic criteria for either one. Now, vestibular migraine. At least 5 episodes of vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours, a current or past history of migraine, and at least half of the episodes must be accompanied by migraine features. No better explanation by another diagnosis. Okay, so vestibular migraine involves transient dysregulation of central sensory processing, including hyperexcitability of brainstem and cortical pathways. Testing may indeed reveal upregulated vestibular responses, and you may be seeing this in your clinical practice. But these reflect functional plastic changes, not permanent lesions. Vestibular migraine reflects a convergence of neural hypersensitivity and sensory amplification, both of which are plastic. Although migraine biology, of course, has a genetic and physiological basis, unlike structural lesions, its patterns are inherently plastic and modifiable, placing it near the neural circuit end. And now Meniere's, which as you see, I've placed in the middle of the spectrum. 2 or more spontaneous episodes of vertigo, each lasting 20 minutes to 12 hours, accompanied by low and mid frequency sensory neural hearing loss in the affected ear, and fluctuating oral symptoms like tinnitus, fullness, or hearing changes. No other cause identified. Now, Meniere's is traditionally understood as a structural condition due to the proposed mechanism, which is endolymphatic hydrops, but there is significant variability and controversy around diagnostic criteria and pathophysiology, as well as actual prevalence due to potential overdiagnosis. There are people out there who say that many people with Meniere's actually have vestibular migraine, but I am not here to weigh in on that because even with confirmed Meniere's, central sensitization and maladaptive compensation can perpetuate symptoms even after peripheral input stabilizes between episodes or after treatment. There's even some evidence that stress can modulate the frequency and severity of episodes. This blend of peripheral pathology and central modulation places Meniere's squarely in the center of the spectrum. All 4 of these show that many, if not most, chronic dizziness symptoms are the result of cause number 2, failure of the nervous system to adapt. This is highly influenced by psychosocial factors, which we will be discussing at length today. And that means that these must be addressed directly via assessment and treatment. And this explains why biomedical treatments so often fail. We are targeting the wrong problem, or at least targeting the problem incompletely. Let's look at how these conditions are typically treated through the current biomedical model, and then examine briefly the evidence that treatment can become vastly more effective if approached via the lens of reason number 2, and particularly via direct psychosocial interventions. With PPPD, we often prescribe medication, vestibular suppressants, SSRIs, and SNRIs, all of which have limited efficacy. These interventions may reduce symptom intensity in some patients, but not all. Reassurance and repeated testing and even vestibular rehabilitation can reinforce threat perception and worsen symptoms. There's published evidence that the addition of cognitive behavioral therapy and acceptance and commitment to therapy, 2 forms of psychotherapy, to treatment for PPPD make it more effective than biomedical treatment alone. We also have research examining risk factors for chronic vestibular disorders, showing that prior adverse life experiences predict the severity and duration of vestibular symptoms, and that anxiety, neuroticism, and pre existing mental health conditions also increase the likelihood of chronic symptoms. Psychological care appears to reduce this risk. MdDS. Vestibular suppressants and other medical treatments are typically ineffective. Vestibular rehab typically fails. Some success has been observed with novel neuroplastic training protocols like the optokinetic head roll, but psychosocial treatments are still emerging. However, my own clinical observations and patient reports strongly support the role of anxiety, stress, and attentional bias in maintaining and exacerbating symptoms. Interventions aimed directly at these have helped many of my own clients improve after years of chronic symptoms. Vestibular migraine. Prophylactic medications and abortive medications can help reduce the frequency severity of attacks, but rarely resolve symptoms alone. They do not address the chronic dizziness and visual motion sensitivity that many patients experience between attacks. Many patients remain symptomatic and their quality of life dramatically altered. Now, while we do not have direct evidence on psychosocial interventions for vestibular migraine, a large body of evidence from the broader migraine literature demonstrates that stress, trauma, anxiety, and cognitive emotional patterns can significantly influence migraine onset, frequency, and severity. Interventions targeting these factors have been shown to reduce migraine burden in multiple studies. Given the shared neural mechanism and plasticity involved, these approaches are highly relevant to vestibular migraine. And finally, Meniere's. Diuretics and sodium restriction may reduce vertigo frequency initially, although that's not clear if it's placebo. Intratympanic gentamicin or ablative surgery can reduce vertigo, but many patients continue to report residual dizziness, tinnitus, or disequilibrium that cannot be fully explained by structural damage alone. Persistent imbalance, anxiety, or motion sensitivity post treatment reflect secondary neural circuit involvement. While psychosocial interventions have not been widely studied specifically in Meniere's, when we know there is neuroplastic involvement, and we're going to talk today about how to identify when there is, we want to target that directly via the kinds of treatments that have been shown to be effective for other neural circuit disorders. So, neuroplastic treatment protocols for reason number 2 often involve both physical interventions like vestibular therapy and psychosocial interventions. We are already often utilizing vestibular therapy, but vestibular therapy does not address some of the most important targets for treatment, as we will soon see, and that is why, as we just talked about, it is not usually adequate to fully address these disorders. Psychosocial treatments address directly fear avoidance, perceived threat, somatic hypervigilance, attentional focus on symptoms, maladaptive feedback loops, anticipatory anxiety, and stress and coping skills. So, I just gave you some evidence that these psychosocial treatments are promising. So, let's now pivot to answering why, because that will tell us when and how to use these treatments, as well as how to develop even more effective interventions. So, to answer this question, we have to ask an even more fundamental question. What is the whole purpose of sensory perception? The purpose is survival. And our sense of orientation is intimately tied to our sense of safety. It is critical for survival. When disoriented, we do not feel safe. And what happens when we do not feel safe? The threat response system is activated. The threat response system consists first of threat being predicted by diffuse brain areas, but especially those classically associated with the fear response, like the amygdala. That activates the sympathetic branch of the autonomic nervous system, which produces an arousal response. The hypothalamic pituitary adrenal axis is stimulated, producing chemical changes that further increase the arousal response and prolong it. And the result of this increased arousal means increased sensitivity to potential threat and the capacity to take quick action to protect yourself. This is all normal. When the threat passes, the threat response system downregulates automatically. But sometimes the threat response does not downregulate, and this can occur for one of two reasons, which are going to sound very familiar to you. Reason number 1, there is structural damage interfering with the brain's ability to orient and feel safe. And reason number 2, the brain becomes hypersensitive and interprets safe signals as dangerous, creating a self perpetuating loop of perceived threat and symptoms. In other words, the central nervous system becomes the cause of the symptoms. Reason number 2 is described by the term central sensitization. In this state, the brain begins to overreact to stimuli, treating safe or neutral signals as dangerous. The symptoms themselves then trigger the threat response, and that heightened response further amplifies and reshapes how the brain perceives those symptoms. Put simply, symptoms activate the threat response system, the threat response system increases symptoms, and over time, this rewires perceptual maps, entrenching symptoms further. Now, central sensitization is thought to play a role in many chronic symptoms, including PPPD and other functional dizziness, as well as migraine disorders and chronic pain. But vestibular research has indeed indicated that perceptual maps in the vestibular system are influenced by the perception of threat. When these maps are being influenced by threat perception, they become less flexible and less likely to reflect the reality of sensory input, leading to prediction errors and dizziness. I often tell my clients your brain is much more interested in keeping you alive than being accurate. So now that you understand both predictive coding and central sensitization, it becomes very clear why we need to directly address central sensitization specifically for the effective treatment of these patients. It is not enough just to know the problem is coming from the brain. So now I'm going to put it all together for you in this general framework for understanding chronic dizziness. So let me orient you. Up on the upper right hand corner, we have biological or psychosocial factors that may set off symptoms. But predominantly psychosocial and stress related factors are what keep symptoms going. Now, we want to contrast this, of course, to something like a schwannoma, in which biological or sensory factors are the driver. When life or internal stressors exist on the bottom right here, they sensitize the nervous system to threat even more, amplifying the fear and threat response. Think about it this way: if you're going through a really stressful period of time, not sleeping well, worried about work or your family, and someone slams the door behind you, you're going to jump more than usual, right? That's because your system's already on edge. When we're stressed, the brain becomes more sensitive to anything that might be a threat, even if it's harmless, like a slamming door. But this causes distortions in or failure to appropriately update the perceptual maps we discussed earlier, leading to an increase in symptoms. And then all of those things then sensitize the brain more. And the avoidance strategies people start to engage in lead to a higher likelihood that the perceptual maps will be further distorted and cause prediction errors and therefore dizziness. It becomes its own self fulfilling prophecy, with the fear response and stress leading to alteration in actual brain maps and leading to real distortions in sensory perception. I think it's very important to emphasize this. These symptoms are exactly the same as someone would have with a structural vestibular disorder. It's the same sensory maps that are not accurate. Same symptoms, but different cause. When the problem is driven by plasticity, the solution also needs to be driven by plasticity. The brain learns symptoms and can unlearn them. And just as importantly, psychosocial factors play a role not only in the onset of symptoms, but in the persistence of symptoms. And this is why vestibular therapy alone is often not adequate for these patients. Fear, anxiety, and stress are fed not only by symptoms, but by the person's conscious and non conscious responses to symptoms and other stressors in their lives. So, particularly when biological factors are non negotiable or biomedical treatments are inadequate, psychosocial factors are our main entry point to breaking this cycle. So, hopefully, by this point, I have convinced you that many vestibular disorders, particularly the chronic ones, are being driven partly or fully by neural circuit factors. So, if that's the case, the purpose of the assessment now pivots from why did this person become dizzy to why did this person stay dizzy? So, our assessment is here to look for evidence that the brain has sensitized and is now the source of symptoms. In other words, are we looking at a reason number one situation or a reason number two situation? And I feel compelled to say here, this is going to be hard for many of us who were educated in a biomedical paradigm. Not the purpose of this assessment to diagnose, describe, or predict outcomes based on specific symptoms. Not to say that the symptoms are totally irrelevant, but once we've determined that the pathology is actual central sensitization, that becomes the target of treatment, not the symptoms themselves. So, this assessment starts with the exclusion of medical diagnoses that could potentially be causing symptoms. And if you don't currently work with a neuro-otologist, neuro-ophthalmologist, or at least an otolaryngologist or neurologist with vestibular specialization, I highly recommend a referral to one of them. We want to rule out BPPV, vestibular neuritis, and labyrinthitis, neurological conditions and diseases, as well as other health related conditions that could potentially lead to chronic symptoms. And from there, we're going to transition into some of these specific assessment tools. The first one is the FIT, the modified FIT, which is the functional, intermittent, and triggered test. This is my own creation based on the incredible work of Dr. Howard Schubiner, who created the original FIT test for chronic pain. There are 34 items on this checklist, and I'm not going to read them all to you, but I'm going to give you some highlights. Ultimately, what it is intended to do is look for signs and risk factors for central sensitization. Here are some of the items. Your medical testing does not fully explain your symptoms. Movement, position, and activity triggers are inconsistent. Symptoms are lower when you're busy or not paying attention to them. Symptoms are triggered by relatively gentle stimulation. You have a history of chronic, unexplained medical issues like chronic pain. Extreme or unusual stress preceded your symptoms. You would not want a child you loved to have had your childhood. Again, all of these items point in the direction of central sensitization. You're also in your intake paperwork probably going to want to look at life stress, some options here on the screen. Although the interview is going to give you far more useful information, it still is a way of setting up that conversation that you're going to be having later about stress. You can also look at resilience, some great options here on the screen. And you can, of course, and should look for a baseline for symptoms using the DHI, NPQ, and or VVAS also here on the screen. And I suggest also a baseline for the distress that the patient is currently experiencing, looking at both anxiety and depressive symptoms as a baseline. Now, we are ready to move on to our interview. And to remind you, we are not looking at biological and sensory factors to figure out what originally caused symptoms. We're looking at the other factors to determine if central sensitization has occurred so we know if those interventions will actually be effective. So ultimately, you're starting your interview with, of course, the patient's goals for today's appointment. And this is also a good time to ask the patient if they understand and or agree with the diagnosis they've been given. Often patients will not volunteer this information unless you ask, and this can start to prompt some of the doubts that might be addressed later in treatment. You're going to ask about symptom onset. And yes, of course, this can give you clues about what started them if no diagnosis has been made yet. But we really just want to know what the onset process was like for the patient, which is going to give you a lot of very rich information about what psychosocial factors were involved in the onset, as well as what might be keeping them going now. Was the onset traumatic? Observe carefully the levels of distress. Is there a hypo or hyper response to this question? How did doctors and family respond to distress? What was the patient told? Is the patient responding appropriately to the distress now? And importantly, what was going on in the patient's life at the time when symptoms started and in the 6 to 12 months prior? Have those stressors been dealt with? You are normalizing that stress affects the nervous system by saying things like, we know from research that stress can make the nervous system become more sensitive to illness and symptoms. It often shocks me, although it really shouldn't shock me anymore because it's happened so often. I am often the first provider to ever ask the patient what was going on in your life when the symptoms started. And if you don't feel comfortable asking that question, you can say something like, has there been anything going on in your life that might put your system a little bit more on edge or be more sensitive to danger? You want to check to see if the patient has been going through major life transitions, positive or negative. You're observing to see if the patient is an overcoper who downplays the potential impact of life transitions. You might also notice some patients become very overly dysregulated in response to life transitions. What's currently going on in the patient's life? And are the patient's reactions to stress, symptoms or otherwise, adaptive or maladaptive? Adaptive would look like self care, self compassion, acceptance, mindfulness, seeking social support, and hopefulness. I have a long list of maladaptive ones, but they include things like self blame, guilt, shame, isolation, helplessness, avoiding triggers, constantly researching and talking about symptoms, ruminating, catastrophizing, projecting, fixating, and obsessing. Now, of course, all of these are understandable responses to the distress of having a chronic vestibular problem, but these are also good targets for treatment. Now, at this stage of the process, especially if medical issues have already been ruled out, you are going to be very well positioned to make a diagnosis and determine if there is actually contribution from a neural circuit issue going on here and or if the problem is fully a neural circuit one. As a diagnostician, this is where you are going to change people's lives. You want to start by naming the diagnosis, maybe even saying this is just a description of symptoms if appropriate. You want to describe the neural circuit component, and you want to talk about prognosis right away. I'm now going to give you some talk tracks. The first one is for people whose symptoms or diagnosis place them on the purple end of the spectrum, where there's a clear neural circuit issue or an exclusively neural circuit issue. Your brain is making a mistake in how it's processing signals. That is what's causing your chronic dizziness symptoms. While symptoms are real and understandably very distressing, they are not a sign that something is permanently damaged or wrong with you. We often describe this as a software problem rather than a hardware problem. Your inner ear and nervous system are working well enough for you to feel steady, but the way your brain is interpreting those signals is distorted. The good news is software can be updated. Many people with symptoms like yours have been able to retrain their brains and recover. Let's talk more today about how to begin that process. And now, for a condition that is partly structural, another talk track. It looks like part of what is causing your symptoms is structural, something in your body. And part of it is how your brain is processing signals. Over time, your brain can start to overreact to certain signals, even if the original problem has gotten better or stayed the same. That brain overreaction can keep symptoms going. We often say the hardware, your body, may have had an issue, but now the software, how your brain processes things, is also involved. The good news is software can be updated. And when we work with both parts, the body and the brain, people often feel much better. So now we're going to talk about your choice of words, management versus treatment. I was taught as an audiologist to use the word management. And as we discussed earlier, patients are often told that their condition can only be managed, not treated, and that they'll have to live with it forever. But I've come to realize that this is simply not an evidence based conclusion. It's a reflection of uncertainty, not inevitability. The reality is, structural abnormalities often do not account for the persistence of symptoms in chronic vestibular disorders. And in conditions like PPPD, MdDS, and vestibular migraine, which constitute the majority together of chronic vestibular disorders, there is strong evidence for reversibility. And perhaps more importantly, when we tell patients recovery isn't possible, we are not just making clinical judgment. You're not just telling it like it is. This is not a neutral statement. You are directly delivering anti treatment, a nocebo. We're reinforcing the very circuits that need to be rewired by feeding more fear, more helplessness, and more resignation into the chronic symptom cycle. It's kind of like there's an actual car crash on the highway. There's debris everywhere, and there are emergency vehicles present. And of course, traffic grinds to a halt. We end up with a huge jam. Eventually, the crash is cleared, but hours later, traffic is still crawling. Why? Because lanes are still closed, drivers are still rubbernecking, maybe there's still debris on the road. In other words, the system hasn't returned to baseline. The flow hasn't recovered. Would it be correct in this case to say, well, traffic is still slow, so there must be a new accident, send in the ambulances? No, it's obvious that a new accident isn't actually the cause of the problem here. This is what it's like when we tell people they can only manage their condition or reflexively send them to vestibular rehab. We're sending rescue crews to a crash that no longer exists, ignoring the actual contributors to the jam. We need to treat the jam, the system that is stuck. That's why I think treatment is the correct term. Now, you may not buy into everything that I just said, and that's okay. It's okay to say, we're not sure yet, but I've seen others just like you recover from chronic symptoms. It's okay to say, the research is still in its infancy, but I've seen others just like you get back to living full and happy lives. These are true statements. How you talk to patients sets up their trajectory through this entire chronic vestibular disorder. You are setting them up potentially for the rest of their lives when you name a chronic condition. Do not take that lightly. And what helps them get better? Appropriate treatment that targets the plastic, changeable cycle via psychosocial interventions, sometimes in conjunction with physical interventions that also target neuroplasticity, like vestibular therapy. Psychosocial treatments target the following: pre existing trauma, mental health issues, symptom onset, other life or internal stressors like stressful life events, relationships, or the patient's way of relating to self, low self worth, perfectionism, etc. Avoidance behaviors like over researching, catastrophizing, fixating, what ifing, avoiding triggers. And you personally may not feel comfortable including these aspects in your work with patients, but you do need to understand them today so you can make the appropriate referrals and, most importantly, give hope. So, just a brief overview of the evidence that we have for psychosocial treatment of central sensitization disorders in general. We've already seen that adding CBT and ACT has been shown to make treatments more effective with vestibular disorders, but we have much more research, good research, on central sensitization disorders, including chronic pain, fibromyalgia, chronic fatigue syndrome, and migraines, all of which share the same mechanism of central sensitization with chronic vestibular disorders that are on the neural plastic or the neural circuit end of the spectrum. Pain reprocessing therapy, it's an evidence-based approach for chronic pain, and it retrains the central nervous system responses to pain signals using education, mindfulness, somatic, and exposure practices. This helps address the fear, anxiety, stress, and avoidance components of that cycle. Similarly, emotional awareness and expression therapy has also been developed specifically for central sensitization disorders, and it's been compared to cognitive behavioral therapy and been found to be superior for chronic pain. EAET, or emotional awareness and expression therapy, breaks the cycle of sensitization in a slightly different way, but also targets stress and anxiety responses using a psychodynamic model, which is, of course, outside the domain of this particular talk. Now, we also have treatments that are intended specifically for obsessive compulsive disorder and general anxiety disorder or generalized anxiety disorder, like exposure and response prevention and inference based CBT. These are also quite important because there's so much overlap between people who end up with a neural circuit dizziness problem and people who also concurrently have an anxiety disorder. And finally, there are experiential therapies that are based on memory reconsolidation principles for people who have trauma or stressors that go a little bit deeper. Memory reconsolidation refers to a body of research examining how psychotherapy can permanently alter brain circuits associated with trauma and stress rather than just managing them or counteracting them. This is probably sounding familiar after the topic of our talk today. Modalities include internal family systems or IFS, AEDP, accelerated experiential dynamic psychotherapy, coherence therapy. All three of those I am trained in, as well as EMDR and somatic experiencing, among others. So, this is my general framework for how I work with people who have a chronic vestibular disorder, particularly, of course, those on the purple end of the spectrum: education, engagement, cognitive and behavioral skills, and emotional skills. And we're going to review each one briefly. The education component, you are validating their experience of numerous symptoms, and you are also explaining predictive coding and central sensitizations so patients understand that the problem is in the brain and can be rewired. This is probably going to be the most important thing for you to understand from this presentation, as this is what you will be doing if you are primarily a diagnostician. You have some resources here on the slide: my YouTube channel, which I update weekly, and my free course. And we mentioned that earlier. That's available again for free on my website. You can take it, your patients can take it, everyone can take it. You're also welcome to use these slides if they're helpful for you. And re engagement means breaking that cycle of avoidance that's feeding the fear and anxiety cycle. There are multiple ways to do this. One of them is somatic tracking, which is a meditative way of approaching symptoms rather than avoiding them. There are many samples of somatic tracking on my channel. You can simply search YouTube for my channel and somatic tracking to hear what this sounds like. Also, graded exposure, which also helps directly stop the avoidance cycle, and vestibular rehabilitation when approached differently. Vestibular rehabilitation for these patients needs to be focused on training the central nervous system rather than trying to fix a pathology. We are trying to break fear circuits while exposing the brain to the things it is misidentifying as dangerous. And then finally, as we've talked about at length already today, CBT and ACT is supported by literature. Potentially more effective modalities are PRT and EAET. But not everyone needs therapy. Journaling is actually very effective and can be done at no cost, and pretty much anyone can do it. There are some guidelines in my free course for how to journal to help someone with a chronic central sensitization issue. Now, when someone does have ACEs, so adverse childhood experiences or trauma, I'd very strongly suggest referring to a trauma therapist, ideally one who has experience with the memory reconsolidation related techniques we talked about earlier, or an ATNS practitioner, Association for the Treatment of Neuroplastic Symptoms. I am a member and we have practitioners worldwide. My most important message to you today is that this works. This is not just conceptual or theoretical. This makes an enormous impact on the patients you serve. This is Andy, who, when I first met him, could not look at a screen, and here he is at an open mic night. This is Janice, who was confined to her home for a long time after being told, as you heard earlier in the presentation, that she would be lucky to have more good days than bad days. Here she is enjoying the hot springs with her wife. And this is Natalia, who just a few days ago braved a trampoline park with her toddler and her baby and had no symptoms for 2 hours. And this is Chris, who used to suffer drop attacks in public. And here he is out on his walk run with our unofficial mascot, Supergirl. And what about Alex, Dr. Uzma, and Rhea? Well, if you want to hear more about how they're doing, you're going to want to watch their full success stories on my YouTube channel. I've included the links here. They will blow you away. And they will also explain very clearly how they implemented everything we just talked about in this presentation. Now, as we close, I ask all of you to consider why you entered your field in the first place. You want to make patients better. You want to help them. Hope is one of the most potent medicines that you have to offer your patients. And I hope that what you take away today from this presentation is you have so much more hope to offer these patients when you understand and treat them as whole people, not just an ear. Thank you. All right, everyone. Thank you for sticking with me through this whole presentation. As I said at the beginning, please share this far and wide. I want people to understand why all of the things we talk about on this channel are relevant and useful and scientifically supported, not just something that I made up or you made up. There's actually real evidence that this stuff helps and works. I hope that this was helpful and this continues to help anyone who's suffering from chronic dizziness or other chronic symptoms. I hope this helps the medical professionals who want to help you. And thank you again for all the inspiration and support. We'll talk to you soon. Bye.